I'm Dr. Jonas Swartz. I'm here with Dr. Bev Gray, and this is Outlawed.
Today we're going back to school and learning about what is an abortion. We feel like we've gotten pretty far into our content, but haven't explained exactly how people have abortions in the U.S.
You may not need to know from us what the counseling is around a medication abortion or what the counseling is around a procedural abortion, but we thought it was important to have that content available as part of the podcast.
Right. And since, 1 in 4 people capable of pregnancy have had abortion care in their lifetimes, a lot of our listeners already know what it is because they've experienced it. And 1 in 5 early pregnancies end in miscarriage. And the care that we provide for miscarriage is the same as abortion care. So a lot of those patients know kind of what the options are for management of miscarriage and abortion because they've experienced it too. So a lot of our listeners already know, but maybe you want to know more details from a medical provider, and so that's what we're here to provide.
This episode's a little longer, and the most interesting part is Diana Green Foster, who is a MacArthur genius and the principal investigator from the Turnaway Study, which we'll talk about later. And she's toward the middle and end of the episode. And so in the show notes, you'll see a timestamp. And if you just want to skip ahead to the timestamp and skip the Bev and Jonas part, it won't hurt our feelings. We'll never know.
Well, it might hurt our feelings a little, but we'll get over it because she is the most important part of the episode.
We'll never know.
We'll never know. Okay, fine.
All right.
All right. So many times we have patients who come to clinic and they haven't decided if they want medication or procedural abortion. How do you approach that conversation with them?
I try to figure out what they want and what their priorities are. And it is a really personal decision. Both work really well. Both are really effective. And so what I want to know is, do you want to take pills and then expel the pregnancy at home, have some pain, but have that happen at home in your own comfortable environment? Or would you prefer a situation where you get it completed very quickly, but it's in the office and is a procedure? What do you ask?
I mean, I ask those same things. I think people have when you talk about what the experience is like for medication versus procedural, people have a pretty strong inclination of where their values are and what they want. Many patients have already experienced a miscarriage, and so they may have experienced either a spontaneous miscarriage or needing a procedure for a miscarriage. And just to highlight that those procedures and medications are the same for abortion care and miscarriage care. So a lot of people already have an experience at baseline. And so I do the same thing. I just try to figure out what aligns with what their comfort level is. Some people are uncomfortable with uncertainty of when the medication may start working or having heavier bleeding at home. Some people may have a history of trauma, and a procedure and an exam in the clinic doesn't align with what they need for themselves. So I think really trying to figure out what's most important for them.
How does medication abortion actually work?
So medication abortion is a combination of mifepristone and misoprostol. They're like a team, like peanut butter and jelly.
Biscuits and gravy.
Biscuits and gravy. And the mifepristone works to prepare the body for the misoprostol. And mifepristone is a medicine that is an anti-progesterone. If you want to know like the scientific nitty-gritty, we'll have some resources online about where you can find more information about that. But essentially, you need progesterone to support the early pregnancy. And if you stop it from working, it makes the misoprostol much more effective to cause the pregnancy to expel from the uterus and the body.
And then the second medication that we use is misoprostol, and that's a prostaglandin. And what it does is it gets your uterus to contract and to expel the pregnancy. It also is good for protection against GERD, so that's nice.
Yeah.
It helps with heartburn.
Yeah. That was its original use. Right. So the combination of them together are, more than 98% effective for early pregnancies and very safe. And despite information about the concerns about mifepristone, it's a very safe medication.
And in general, people take the medications over a couple days. So they take the mifepristone either in the office or at home, and then they wait somewhere from 6 to 48 hours to use the misoprostol. And then shortly after taking the misoprostol, then they start to have heavy cramping and bleeding to actually pass the pregnancy. So the experience of the abortion is a little longer than for a procedural abortion.
And very much like a spontaneous miscarriage. All right, moving on. So that was medication abortion. We'll talk about procedural abortion. So for procedural abortion, you have to open the cervix and then remove the pregnancy tissue. And depending on how far along the pregnancy is, opening the cervix part could be in the clinic that same day. So most abortions in the first trimester don't require additional medicines or procedures to open the cervix, aside from just using the dilators. But beyond the first trimester, we'll use medication to help soften or open the cervix, or sometimes we'll even place dilators in the cervix to help the cervix more slowly dilate. And the second part of the procedure is removing the pregnancy. So if someone is early in pregnancy, all of this happens in under 5 minutes. The cervix is gently dilated and then either removed with a handheld suction device, or a suction machine is sometimes used for patients beyond kind of 10 or 11 weeks. And then for patients beyond 14 weeks, the cervix has to be dilated a greater amount as the pregnancy and pregnancy tissue is larger. And so that happens either through dilation evacuation or to a lesser extent, more like a labor induction, kind of very similar to when people come in and give birth.
And on the, I feel like whenever I give this talk for students that they're always surprised, and we often can hand out or, pass around that manual vacuum aspirator, which is like a little syringe. And then next to it, the colored cannulas that you can see are just plastic straws that go through the cervix into the uterus and take the pregnancy out. And those, we measure them in millimeters. So for example, an 8 millimeter cannula is what you would use for an 8-week gestation. And so the pregnancies are really small at that point and can pass right into that little syringe tool or into the vacuum aspirator.
Yep. And it's not a lot of tissue. And I think sometimes even oftentimes patients want to see the tissue and they're surprised with how small it is. And I think when we see things on an ultrasound screen in our minds, it's like a lot bigger than it is in reality. And so for many patients, that sort of helps them wrap their mind around kind of how much tissue or how much is there.
And also less recognizable as something that looks like an embryo even, right? Until you get to maybe 10 weeks, I don't generally expect to see anything that even resembles fetal parts or an embryo.
Yeah. Yeah. And that's surprising to a lot of people.
Most of the procedures that we do have pretty similar risks. And the biggest risk that we talk about in procedures and the biggest risk in the setting of abortion is bleeding. And that bleeding can sometimes be so heavy that someone would need a blood transfusion, but that's really, really rare. But bleeding more heavily than we anticipate. There's a risk of infection, and usually we give antibiotics to prevent that with a procedural abortion. There is a risk of a uterine perforation or making a hole in the side of the uterus. That happens about 1 in 500 times, so pretty rare. And even more rarely, if there is a perforation, then we can cause damage to other organs that are around the uterus, and someone could need further surgery. There's a risk of ongoing pregnancy, which is really low with procedural abortion. There's a risk of retained tissue, so leaving some of the pregnancy tissue behind.
And would you say that the risk for abortion procedure care is any different than if you're caring for someone with a miscarriage?
No, exactly the same.
And I would say in my experience that patients who have had a miscarriage for a while actually experience more bleeding than patients seeking abortion care.
Yeah, so it's maybe riskier.
Yeah.
It's 14 times safer to have an abortion than to carry a pregnancy to term if we're just thinking about the risk of death. It also helps you avoid medical risks that happen with ongoing pregnancy. So high blood pressure or preeclampsia or diabetes that can occur with pregnancy, or the need for a C-section, right? 1 in 3 patients is going to have a C-section, which is a major abdominal surgery. And abortion's much safer than those. It's also a lot safer than driving a car, comparably safe with using a tampon. So it's a really safe procedure, even though it is often demonized or discussed as unsafe by people who oppose abortion.
Right. And it's comparably safe. A procedural abortion is comparably safe as a medication abortion. The risks are slightly different. So lower risk of procedural complications. There's slightly higher risk of bleeding or needing to come in with heavier bleeding, risk of retained pregnancy tissue or ongoing pregnancy that requires a procedure. Risk of a sensitivity or allergy to medicine is pretty rare. And as we discussed earlier, the medicines are safe. What else would you say for medication?
Well, I mean, I just think big picture, we're talking about how safe this is. So why is it so restricted?
That's a really good question. And I think it's restricted and the forced biased counseling is put in place. All these restrictions are put in place just to make it harder to get care. And we know from a study of an unbiased group of scientists and medical professionals that restrictions don't make care safer.
They just make it more difficult to access.
Yeah. All right. So we're going to do a case study of 3 different states and what it would look like to seek abortion care in those states. But first, let's go back in time a little bit. So on the day of the Dobbs leak, in every state, there was at least one provider of care or one clinic where patients could go to seek care. And then very quickly, within the next 6 months, we saw access shrivel up in all of these places. And those patients in those states where care was no longer available either didn't get care or had to travel for care.
Yeah. So we're going to talk about the same patient, but we're going to pretend that patient is presenting for care in 3 different states. And so this patient is 32 years old, and let's say that she's around 17 weeks gestation, so into the 2nd trimester. And she presents to labor and delivery because she's had fluid leaking from her vagina. And when she has an exam, it confirms that she has broken the bag of water around the pregnancy, that she has a rupture of membranes. And the ultrasound shows that there's no fluid around the fetus, and that's a condition that we call anhydramnios. This is a really risky situation for both the person carrying the pregnancy and, unfortunately, is a very poor prognosis for the fetus. So the person carrying the pregnancy, the body is pretty good at protecting you from infection when you're pregnant. But part of that protection is that bag around the pregnancy. And once that bag is ruptured or open, then it's very easy for infectious organisms, bacteria, to travel up through the cervical canal and infect the pregnancy. And that's a really dangerous situation for the person carrying the pregnancy. It can mean that they have really heavy bleeding. It can mean that they have a life-threatening infection. It can mean that they end up in the intensive care unit, that they need a hysterectomy. And so the obstetric standard of care in this case is to offer to empty the uterus. And that could be with a dilation evacuation procedure, an abortion procedure, or it could be through an induction, a labor induction, where we give them medicines to help them expel the pregnancy on their own.
Right. And so it's not only dangerous to the person carrying the pregnancy, but amniotic fluid is actually critical for lung development for the fetus. So amniotic fluid is fetal urine. Fun fact, if you didn't know that already. And the fetus practices breathing in this amniotic fluid, and that helps the lungs as the fetus continues to develop later in the 2nd and 3rd trimester to develop functioning lungs. And so if you lose your amniotic fluid at this early gestational age, even if you make it to quote unquote viability, often there's not enough lung development that's occurred for those infants to survive. All right, so we're going to go to Oregon first and see what happens to this patient. So, 32-year-old at 17 weeks breaks her water, and she's in Oregon.
So I did my residency training in Oregon, and that patient has no barrier to receiving immediate care. They're counseled in the setting that, so let's say they're on labor and delivery, they'd be counseled, they'd be offered a dilation evacuation procedure or a labor induction, depending on what they wanted. They could choose to have outpatient or inpatient care, and they would have no barriers to that care because both Medicaid and private insurers cover abortion, or Medicaid definitely covers it, and private insurers cover it with much more frequency there. And so the patient has all kinds of choices and immediately is able to access care.
Right.
Yeah.
And even if you are an undocumented immigrant, you would still have insurance coverage for chemo. So why don't we all move to Oregon? I mean, Oregon's great, right? I also love Oregon, but let's say we're in Georgia. So patient breaks their water, 17, 18 weeks, and you're in Georgia.
So in many settings, they'd only be able to have care if they were symptomatic. And so we know that they're at high risk once they've broken their water and they present for care. But oftentimes there's a lag before those symptoms develop, before they become infected, before they start bleeding, before maybe they go into labor. And I think in many settings in Georgia, from talking with providers there, they are not able to intervene immediately. They have to wait for those symptoms to onset. Or if they're going to provide care before that, they may have to get hospital approval or an ethics consultation, which delays the patient. But we've cared for many patients who came from Georgia who were sent home to sit in the parking lot or to go home and wait for symptoms to develop and then told to come back. And that's really just a nightmare scenario.
Yeah. I talked to providers in other access states near Texas, and, they describe, hearing stories of patients who are told to go get an adult diaper, hop on an airplane, and just hope you make it to whatever state you're going to.
Yeah. And Dr. Allison talked about that in our Texas episode. I've talked with providers from access states that don't have those barriers about what they do in these situations, just to confirm that I wasn't crazy. And I think they didn't even understand the question I was asking in many cases. They're like, well, what do you mean? Of course this is what you do, right? And so it's just been that big a sea change in the way that care is able to be provided in these restricted states.
Right. And we're going against what is written in the textbooks.
Yep.
All right, let's go to Idaho.
So Idaho's probably the most extreme example, where people may not even be able to access emergency abortion care, and frequently would need to be shipped out of state to be able to get care because of how stringent and strict the law is and how it criminalizes providers.
Yeah. So there are many stories of providers talking about their frustrations, some leaving the state, and just creates larger maternity care deserts.
Yeah, and so maternity care deserts are places where there aren't OBGYNs and hospitals, maybe in a whole county. And so imagine presenting to a hospital with an emergency condition, right? Something's going wrong with your pregnancy. There are people living in those counties, and people in those counties get pregnant, and then having no one to care for you.
Yeah. So we've covered how abortion happens, whether it's medication or procedural abortion, and talking through risk and benefits and how we counsel patients. But now we're going to turn to the real professor. Dr. Diana Green Foster is a professor, a demographer from the University of California in San Francisco, and she is a MacArthur genius. And we're very lucky that she spent some time with us to talk about one of her very famous studies called the Turnaway Study.
Diana's work is called the Turnaway Study because she looked at the differences between people who presented for abortion care and either were able to get that care or were turned away because they were just beyond the gestational age. So it's the best science we have about what happens to people when they aren't able to get abortion care. There's over 100 studies published from this group of patients, this idea, and she's put all of that data together into a book called the Turnaway Study. And her sister wrote this great play, the Turnaway Study, which brings the study and her work to life. We started off by asking Diana where she came up with the idea for the Turnaway Study.
Around 2007, the conversation in this country was whether abortion hurts women. And there were laws passed that restricted access to protect people from making that decision, and billboards, even in the San Francisco Bay Area, that said abortion hurts women. And the Supreme Court, Anthony Kennedy, allowed abortion restrictions to stand because, although he admitted there were no reliable data, he thought it seemed unexceptionable to conclude that women would regret their decision and be depressed if they had abortions. And what he didn't consider was if you restrict access to abortion, then you have to wonder how depressed people might be if they didn't get an abortion. And in the quest to understand, does abortion hurt women, what was missing was a comparison group. So there were studies that just followed people who got abortions over time and found they weren't particularly depressed. But what would it be like if they hadn't gotten their abortion? And so that's what the Turnaway Study did. And it was really sparked by Dr. Eleanor Dry, who runs the Women's Options Center at San Francisco General Hospital, said to me, I wonder what happened to the people we turn away. And it was a light bulb. That was exactly the sample we needed, is to follow people who wanted an abortion, couldn't get one, and people who did want an abortion and did get it, and follow both groups over time to see if their lives diverge, and if so, how.
Part of the reason that the setup for this study is so clever is that the question had been really difficult to answer. So Diana mentions that the Supreme Court had essentially asked, what are the mental health effects of having an abortion or not having an abortion? And that in the absence of data, they assumed that the effects of having an abortion were negative. Well, how do we study things in medicine or in science? The gold standard is usually a randomized controlled trial where you take a group of people who are alike. So in this case, a group of people who want an abortion, and you randomize them to one treatment condition. So you would randomize half the people to have an abortion and half the people not to have an abortion. The issue is that is not an ethical study in this case. You can't randomize people to have or not have an abortion. Previous studies had looked at this question by comparing people who had an abortion and didn't have an abortion, but the didn't have an abortion group was not the same in composition as the had an abortion group. You can imagine that if you're pregnant and you're seeking an abortion, the circumstances might be different than if you're pregnant and you are experiencing a miscarriage, or you're pregnant and you go on to have a delivery. Those groups of people may be different. So in the Turnaway Study, what they did was they went to clinics across the country and they looked for people who were presenting for abortion care either right before or right after the gestational age limit at that clinic. So let's say the gestational age limit at a clinic was 20 weeks and 0 days. They could enroll people who were in their 19th week of pregnancy and enroll people who were in their 21st week of pregnancy. The people in the 19th week of pregnancy were able to get that abortion care, and the people who were 20 weeks or just above the gestational age limit, so in that 21st week of pregnancy, weren't able to get the abortion care. Well, those people had all been seeking abortion, and so they were pretty similar groups. And that gave the best comparison of what happened long term to people who were or were not able to access abortion. The other amazing thing about this study is that they followed people who were participating for 5 years. So they have long-term data on what happens to the individuals who participated in the study.
So that's what the Turnaway Study was, and maybe it was primarily about mental health because that was our political dialogue at the time, but clearly the issues are much bigger than mental health. When you ask people about their reasons for abortion, they understand that abortion or birth will affect a huge number of aspects of their lives. So we didn't just ask about their mental health, we asked about their physical health and their economic well-being and their kids and their life plans. So what we find is that in the short run, people who are denied abortions have worse mental health. They have lower self-esteem, higher anxiety. But we were calling people every 6 months, and by 6 months to a year, symptoms of depression, symptoms of anxiety, self-esteem, life satisfaction, all of PTSD symptoms, all of those were the same and continued to be indistinguishable for the next 5 years. So there isn't a long-term harm of abortion, but there's also, I think surprisingly, not any long-term harm to mental health-wise to carrying an unwanted pregnancy to term. So that is certainly a surprise, I think, for people who feel like it's a major life change. But there are a ton of other ways in which the two groups diverged. It just wasn't a mental health story. And you won't be surprised as a physician that the physical health of people who carried to term was much worse not just because childbirth is so much more serious of a physiological event, than so much greater risk associated than having an abortion, even a later abortion. But we actually saw worse health that lasted for years for the group that gave birth. And that, is because, and I still haven't found an elegant way to say it, but pregnancy, carried to term, childbirth is a massive physiological risk, and we take that for granted because women do it. Yeah. Because childbirth is natural, and it's also associated with huge risk and every organ stress test. And we see that 2 women died of childbirth, which is a shocking rate of maternal mortality. It highlights how risky that is. But then among the people that survived, even we see higher rates of chronic pain, hypertension, and overall worse physical health for the people who couldn't get their abortion compared to the people who did. Most people don't realize that when they're planning children, and even realizing it, many of us choose. But it really raises the stakes for forcing people to do it when they don't choose, to really understand what we're asking for. If we say, the solution to abortion is to place your child for adoption, completely neglects the physical health aspect of carrying a pregnancy to term.
As Diana mentions, the team thought creatively about the ways being able to access or not access abortion might broadly affect people's lives. And one of the ways they considered, but that was difficult to measure, were the economic consequences of not being able to access an abortion. Luckily, they got some help.
An economist at the University of Michigan, Sarah Miller, reached out to me and said, what you should do is match the people in the study to their credit reports, because credit agencies don't know if you've been pregnant. They don't know that you sought an abortion. They don't even know that you had a birth, but it's this measure of your economic well-being. And she did that work, and we found a higher chance of eviction, higher chance of foreclosure, larger amount of debt, greater likelihood of having a low credit score. So economic insecurity that lasted the more than 4 years later, you could see worse economic health. So it's not a surprise, because people told us at the beginning, I can't afford to have a child, and they understood. But they also told us, my relationship's not good enough to support having a child, and we saw that relationships dissolve regardless of whether you have a baby or a child. They told us they need to care for their existing children, and we see their existing children do worse economically and developmentally. They say it's not a right time for a child, and we see that maternal bonding is worse with the child born because the mom was denied an abortion compared to next child born, someone who was able to get an abortion and plan or accept the timing of the next pregnancy. And so the biggest surprise is that we didn't need to do this study, because we could have just asked people, why do you want abortions? Because they were exactly right in predicting the outcomes. Now, of course, if we hadn't done the study, people wouldn't necessarily believe women about their reasons. Right. And we could show the reasons they give us are exactly the outcomes that they will experience if they can't get an abortion. So I have an older sister. She works in a small community theater in upstate New York. And I thought in 2019, when I was writing the book, that I would have a book tour. And I didn't want to just get up and talk about science and p-values and graphs. I wanted to have the voices of the women from the study with me. And so I said, can you go through an excerpt and make me some kind of little, theatrical treatment, so that maybe I'd have people read it. I don't know how I'll do it, but I don't want to be the only one talking. And then the pandemic hit. There was no book tour, and she had a lot of time. And so she wrote a whole play.
Sorry, was that agree? Oh, okay, disagree.
Have you had another abortion in the 6 months since we last spoke?
Okay, these last questions are open-ended, so you can answer in your own words. How do you think your life will be different a year from now?
And it is she based it on as if I were giving a lecture on the day that Dobbs was announced. In fact, I was, in my pajamas when Dobbs was announced, but theater is better than real life.
Okay, an important question here. Why do people decide to have an abortion? Take a moment and make a list in your head with some of the reasons. Okay, stop. Congratulations. You have now given this more thought than many policymakers when they're deciding on abortion restrictions.
But the idea is to kind of humanize the experience of needing an abortion and talk about the consequences when the government tries to prevent people from doing what they think is right. My sister just she's in New York City for the year, and she went to Queens to the New York Department of Health, which has an hospice in Queens, and they did a reading, like a lunchtime reading there. And she called me like practically in tears after that reading because, first of all, they'd done an amazing job, and then they'd followed up with all the things that the State Department of Health is trying to do to make things better. Oh. And also she thanked me for her writing the play, which cracked me up. Like, you want to thank me for you doing the work. I have two grandmothers who each had unwanted pregnancies. So one was in New York City during the Depression. She got pregnant and she knew they couldn't afford to have a kid. And so she was married to my grandfather, and they went to Puerto Rico and got what was an illegal but totally safe abortion. And nobody particularly talked about it in the family. But then when she died, my grandpa said all donations to Planned Parenthood, which, she'd never been a big vocal abortion advocate. So that was a little surprising. And yes, we sort of knew, but it wasn't something we talked about. And the other grandmother I only met when I was 12. She had become pregnant when she was 19 by a golf instructor who was clearly a total jerk. And he told her when she said she was pregnant that if she told anyone it was his, he would get his friends to say it could be theirs. Mm-hmm. So she was 19. She went to her very Christian religious parents, who were appalled because for them, the big shame was an out-of-wedlock pregnancy. And they sent her to Salvation Army Home for Unwed Mothers, where she gave birth to my mom. Do you want the long version?
It's up to you.
So she gave birth to my mom, Salvation Army Home for Unwed Mothers. Her parents hadn't visited her the whole time. Mm-hmm. And she didn't know, does she have a home to go home to? But she was so disabled by delivery, she needed a place to recover. So she went home with a girl that she had met there, who had also just had a baby. And while she was unable to walk, recovering at this girl's home, the girl's brother raped her. And he raped her because she was already no good, which is just heartbreaking. The idea, first of all, to rape somebody who's like having a medical recovery, but because she's no good, she's not a good girl anymore, so you can do what you want with her. So traumatizing. And when, so she went on with her life. She never had kids. She wanted them. She never got to have them. And my mom found her when my mom was in her 40s and Dorothy was in her 60s, and I was only 12. And Dorothy, my mom and Dorothy had a little bit of hard time with each other. Right. My mom wondering why was I given up. Dorothy reminded probably of all the abandonment and betrayal that the pregnancy with my mom caused her to experience at the age of 19. But me, I'm just thrilled to have a grandma, and she's like this amazing, physically strong, independent lady, is amazing. So she and I became very close. And we both lived in California. All the rest of the family's on the East Coast. And so we, really became close, and it was wonderful. And these stories of what happened around her birth took a very long time for her to even want to talk about. So, and she was very funny and, yes, independent, but her idea was that her life had been hard because she never found a man to support her. Mm-hmm. And if only she had gotten married and, that she had an adventurous life with a couple marriages, and life would have been so much easier had she followed the traditional model, not gotten pregnant, found someone, married them, had his kids. So later she had dementia, and she nicely never said, "Oh my gosh, Diana, what happened to you? You look so old." She always thought I was in college. She didn't say what's the gray hair? But anyway, I would be with her and she would say, "Oh, a wedding ring. Are you married?" And I'd say, "Yes," even though of course she'd been at my wedding many decades before. She'd be so excited that I was married, and I'd say, "Yes, and I have 2 kids," and she'd say, "Are they his?" The whole idea of, she wasn't particularly proud of my PhD and my faculty job and my whatever, but she loved that I was married with kids and they were his, because it was what she saw she didn't get the normal blessed life trajectory. She was always at a disadvantage. And so it's super, I think my mom's birth put her off track, and though she triumphed in many ways, life was a challenge.
For a longer version of Jonas and Bev's Abortion 101 lecture, check out our YouTube channel at youtube.com/@outlawedpodcast. There's also a link in the show notes. Opinions expressed on this podcast are our own. Philanthropy is helping us highlight these stories, and we hope you'll continue supporting this work by subscribing and sharing the show and getting involved in your local community. This podcast is executive produced by us, Dr. Bev Gray, Dr. Jonas Swartz, and Jane Marie. Production by Little Everywhere. Thanks to Nick Thorburn, Maker, and Patrick Ford for our score, and Jamal Walton for original artwork. Extra special thanks to everyone who lent their knowledge and voices to the show.